Welcome to Global Perspectives. What is the state of healthcare in the United States? For answers, we turn to Dr. Andrew Gurman, President of the American Medical Association.
Global Perspectives with Pulitzer Prize-winning commentator John Bercia.
Welcome to the show, Dr. Gurman.
Thank you. I'm delighted to be here.
So tell us, what's it like to be President of the American Medical Association?
It's absolutely fascinating. There is so much going on in healthcare, in politics, and the intersection between them. It's an absolutely fascinating year to have the honor of being president.
And tell us a little bit about your own practice in Pennsylvania. You're the first hand surgeon, I understand,
That's
to
correct.
be president of the AMA.
I am an orthopedic surgeon. I'm only the second orthopedist to be president. The first was Dr. Louis Sayre in 1870. He was actually the first professor of orthopedics in this country at Bellevue Hospital. So I'm an orthopedic surgeon, but I have over the years specialized more and more in just surgery of the wrist and hand, which is what I did extra training in, and now I just do hand surgery. I have a private office, and this year that private office is kind of an expensive hobby because I'm on the AMA trail a lot, but I still see patients, and I think it's a very important part of what I do.
So how did you get from your practice to the presidency of the AMA? I know you were very much involved with the organization for a long time before you were made president.
Yeah, it's actually a series of accidents. I started off early on in practice with someone else. I used to tell people he was an older fellow. He was probably my age, but he took me to my first Pennsylvania Medical Society meeting. And I enjoyed it, and he took me again the next year. And then somebody kind of tapped me on the shoulder and said, "You should be on the AMA delegation." And I said, "Well, why would I want to do that?" And they said, "Well, you get a free trip to Hawaii." I said, "Okay, I'm in." I went to the AMA. It turns out I never got that free trip to Hawaii, or not for a while anyway. I was impressed at how relevant I thought the things that were discussed at the medical society, both at the state and the national level, how relevant that was to my practice and for the protection of my patients.
So talk to us about the AMA. This is an organization dedicated to the art and science of medicine and protecting the interests of patients and physicians. What does that mean in practical terms in 2017?
Yeah, it's the art and science of medicine and the betterment of public health. That's our mission statement. And it means a lot of things. It means that we advocate for patients in situations where we are the most qualified to give information on their behalf about technical aspects of care. We advocate for a healthcare system that will be accessible to all, that people can get healthcare. And we also advocate on behalf of physicians.
And give us an example of how that might work, say, at the national level.
Sure. We have three strategic objectives, and two of them are relevant to the question you just asked. So one of them is improving health outcomes. We have devoted a lot of resources, particularly in the area of diabetes and prediabetes, as well as high blood pressure, hypertension. There are 86 million people in this country who have what's called prediabetes. And 90% of them don't know it. So we formed a partnership with the Centers for Disease Control, CDC, the American Diabetes Association, and the Ad Council. And we put together a year-long public relations campaign, which is still going on. There's a website called doihaveprediabetes.org, and I would encourage all of your listeners to hit that site, doihaveprediabetes.org. And by answering a few simple questions, it will tell you whether you have a risk of developing diabetes and give you some steps that you can take, either seeing your physician or getting yourself involved in a diabetes prevention program. So that's one aspect of that. We also advocated for coverage for diabetes prevention programs by Medicare. And this year, for the first time, CMS decided that they will cover it starting in 2018. For Medicare beneficiaries. We've advocated for coverage in private insurance. So let me see if I get the list straight. Costco, Lowe's, Delta Airlines, and Iron Mountain are 4 companies I know of, nationwide companies, there are probably more, who have now decided to cover these diabetes prevention programs as a covered benefit. The importance of that is that 30% of people who have prediabetes will go on to develop diabetes if they don't do some things to prevent that. Losing 5% of body weight, which for most people is 5 to 10 pounds. Exercising regularly. Some simple food choices, which can greatly help and improve the health of our nation. Diabetes carries with it a lot of more what we call morbidity, bad things that can happen, amputations, blindness, lots of other things. So that's one area in which we advocate for patients, either for patients directly by making these resources available or indirectly by getting them coverage. The other is high blood pressure, and I don't know how we're doing on time. We could circle back to that.
We can perhaps circle back. Let's talk about access to the healthcare system for the average person. In recent years, it has opened tremendously. More people have access, more people are insured. Where are we in terms of serving as many people as possible?
Well, we're getting better, but there still is a long way to go. People have access when they have insurance, but as you know, a lot of insurances have very high deductibles, have narrow networks, and so there is not as great access as we would like for some people. Look, America has the best healthcare system in the world. If you are anywhere in the world and you're really sick and you have the resources, where do you want to go? You want to go to America, because everybody knows that's where the best care is. But if you live in America and you don't have resources, you may not be able to access that care. People who don't have health insurance live sicker and die younger. We clearly know that. Some people who have insurance but high deductibles still face significant barriers to accessing that care. So that's another of the things that we are advocating for.
What about the issue of prescription drugs? This seems to be something a lot of people talk about. We pay a certain price for prescription drugs in this country. In other countries, oftentimes the price is lower. How do we address that problem? How do we begin to change the system so that Americans aren't paying this disproportionately large amount for prescription drugs?
Yes, that is a complex issue. But I think that the first step is transparency. The fact is that nobody knows what prices the pharmacy benefit managers are negotiating with insurers and with drug company providers, middlemen, manufacturers. We don't know what goes into pricing a drug. We don't know what the R&D costs are. I'll give you an example that was given to me by my local pharmacist. There's a drug called metformin, which is used for diabetes and prediabetes that we talked about before. And I want to get these numbers right, so I wrote it down. These are my local pharmacy's bulk wholesale costs. So this is what he pays his distributor to get these drugs, and then he marks them up however he marks them up, and he sells them. But for metformin, 500 milligrams, that's the lowest strength, it's $6.35 for 100. 750 milligrams, the next tier up, is $9.95 for 100 pills. Now, they also come in 1,000s. Now, it's two 500 pills. Remember, the 500s are $6.35 for 100. For the 1,000 pills, there's only one manufacturer, $563 for 60.
And what is the reason for that giant hike in cost?
We don't know. There is no transparency. There are other examples, but the first order of business is that we need to know how and why drug prices are escalating the way that they are. Doxycycline is a drug, an antibiotic that is used a lot in the Northeast for Lyme disease, which you don't have as much of in Florida. But it's used for other things as well. It was less than $100 for a full treatment. Now it's $750. There's no R&D costs. There's no increased manufacturing costs. It's the same drug it was a few years ago. And it is unexplained as to why the price goes up. There was an antibiotic that had a very limited use made by a company that was bought by someone else. The price was increased 5,500%, and when the owner of the company was asked why, his answer was, because I can.
Yes, I can.
That is unconscionable.
Well, AMA in its advocacy role for patients in this particular area would do what in terms of trying to find out what is wrong with the pricing for a particular prescription drug? Without naming a particular drug, how would you, as an organization, go about gathering information, bringing this to the attention of elected officials, and trying to get the issue resolved?
Yeah. Well, we established a website called truthinrx.org, where we've asked people to provide us with tales of woe, with information like what I just gave to you, and I've actually entered it on that site. And when we collect that information, we bring it to government, we bring it to Congress, we bring it to administrators, and then they have to do with that what they will. The AMA doesn't make laws, the AMA doesn't make regulation, but we do have the power of representing the physicians in this country to go and say to regulators and legislators, our patients need help in fixing this.
What percentage of physicians participate in AMA? Does it vary from state to state? Or is there a national number?
I think that the best way to answer that question is to explain how the AMA works. Mm-hmm. All right. The AMA is a large organization that advocates based on policy that is established by our House of Delegates. Now, that House of Delegates is made up of 190 different state and specialty societies. So when I tell you that the AMA supports transparency in drug pricing, that's because there is AMA policy that says there is transparency in drug pricing. Every practicing physician in this country is represented in that process by at least one organization. I am represented by 6. The American College of Surgeons, the American Academy of Orthopedic Surgery, the Pennsylvania Medical Society, another orthopedic group, and a couple of hand groups. You can be represented by as many as 10 or 11 if you were a gay woman of color who was educated abroad and practiced a subspecialty. So there are lots of different groups. We come together, and as the big tent House of Medicine, we establish these policies.
And all of these are organizations where participation is voluntary, or some of them not, or some of them...
No, it's voluntary. You're
Okay,
absolutely correct.
so including all of the ones that feed into you.
That's correct. But all physicians are represented by groups, even if they are not members of them. For example, there is a senior physicians group. There is no individual membership in this senior physicians group, but they have a seat in our tent. I enumerated the ones that I'm a member of. Most orthopedic surgeons are members of the Orthopedic Academy, but not all. Yet we represent all of the orthopedists.
So you could be a member, a physician could be a member of one of these organizations that feeds into the AMA, but not necessarily a member of the
That's
AMA.
correct. The AMA has 220 some odd thousand members, either through their state societies or direct members. Mm-hmm. But like I said, we represent a much broader scope than that because of the way that we do our business and the way we convene the House of Medicine.
So if a physician has a concern that he or she wants to bring to the attention of AMA, but is not a member and is involved with one of these other organizations, what would that process be like?
Well, there are a lot of them out there who have found my email address and have
I'm sure
not been at all bashful about letting me know what they think. And I think that's great. And I answer all of them. Mm-hmm. So there is direct access. You can go on the AMA website and find my email address. But the way that the policy has changed, which is really, I think, where you want to go, is that a single person can bring a resolution to the AMA House of Delegates through any one of their societies. And that resolution can change or make new policy on a particular issue. And one person can make a tremendous difference. It has happened countless times.
Do you, as an organization, make an active effort to recruit new physicians? You mentioned that there were several 100,000 who are members. What about the ones who aren't? Do you reach out to them on a regular basis to see
Yes.
if they would be interested in joining? And,
Yes.
and what would be their incentive to do so?
Well, we reach out to physicians to engage with them on a number of levels. Certainly joining the AMA is part of it, but more importantly, we want them to understand the issues that are before them. We want them to get involved in advocacy. That's one of my personal passions, is making people understand that advocacy for our profession and for our patients is an important professional responsibility. So we reach out electronically, we reach out by direct mail, we reach out in any one of a number of ways. We send the president to talk to interesting people like you so that we can get on the air. So there are lots of different avenues. And we also do this through our constituent members. So for example, I get a weekly newsletter from the American Society for Surgery of the Hand every week, and it will very frequently have some AMA material in there.
One of the complaints that I hear almost daily from patients and from physicians is the amount of paperwork that is required now. It seems to be piling up, whether it's physical paperwork or electronic paperwork. What is AMA doing in response to that concern? It seems that patients and physicians are spending a much greater share of their time filling out paperwork, and is that in the best interest of patients and healthcare?
Well, the short answer is you're absolutely right. It's horrible. And no, it's not in anybody's interest to be doing that. The system at present is making me the world's most expensive data entry person. And it's silly. We actually did a study recently. It was published in the Annals of Internal Medicine, where we did what's called a time motion study. Rather than asking people, how much time are you spending doing this, we sent somebody around with a stopwatch. And they measured in the course of the day how much time doctors are spending doing what. It turns out that on average, and this is in primary care, physicians are spending 27% of their time doing direct patient care. That means that 73% of the time they are not. And this is important for everybody because it's a terrible waste of resources. And not only is it the physicians that are involved with this, another thing that we've been talking about is the burden of pre-authorizations. An average primary care practice deals with 37 pre-authorizations per week, taking an average of a half an hour to resolve. So that means that essentially a half a full-time equivalent in the doctor's office is spent doing nothing but arguing for authorization of drugs or authorization of tests or authorization of God knows what. Why should you care as a patient? Because if the nurse is spending time doing that, then he or she can't be available to talk to you about this new medicine that the doctor wants you to prescribe or wants you to try, or a new treatment of some sort, that a new diet, a new whatever, that the nurse should be spending time talking to you about. Instead, he or she is too busy doing this kind of stuff. So we've convened a work group on that. This problem also is causing tremendous burnout among physicians, which is a huge problem. The average dissatisfaction rate in the non-healthcare world, dissatisfaction rate with work-life balance, don't like my job, whatever, is about 36%. In medicine, it's 64%. It is over 50% in a number of specialties, and that's causing people to retire earlier. It's causing people to decide not to go into those specialties. And it's ultimately causing the doctors that are there to be so stressed that they're not delivering as good a care as they could be delivering. It is clear from a number of studies that physicians who have good job satisfaction deliver high quality care, higher quality by any measure you care to look at. So you should be nice to us and you should bring us cookies.
So what concerns me is I'm thinking about all of the issues, challenges, problems that you've just discussed. We recently went through a major overhaul of the healthcare system in the United States. We're now going through what likely will be another significant overhaul. What is it that we need to preserve about the system that is in place, and where are there opportunities to make changes?
I think that the most important thing to preserve is the doctor-patient relationship. There is no more intimate act that someone can do than to come to me and say, take care of me. It's a tremendous honor and it's a tremendous privilege to do that. And we sometimes lose sight of that when taking care of you involves all of the other distractions we just talked about pre-authorizations and narrow networks and drugs that we can't get or they're too expensive. But ultimately, the privilege of getting to know you, of taking care of you, of using all of my training so that we as a team can make you healthier and make your life better is an incredible privilege. We have to preserve that. We have to nurture that.
Well, I've personally found that the time I spend with my physicians is very, very limited, often just a few minutes. Most of the time, I don't see the physician. I see a PA, a nurse, qualified people, but sometimes you like to talk to your physician.
Yeah.
And the only physician that I spend a lot of time with is my GP, who has changed his practice so that he only works with a very limited number of patients, and that guarantees a certain amount of time. But I would imagine most physicians can't afford to do that and maintain their practices. So are we ever going to get to the point where you really do have that bond you were talking about, where the physician and the patient actually have the time to know each other and to really understand the patient's condition?
Well, we hope so. And we're working towards that in a number of different areas. There is a series of practice resources on the internet, on the AMA website. It's something called Steps Forward. And you can get to it either through the AMA website or stepsforward.org. These are a series of practice management modules that can help physicians reclaim time. For example, simple things. In a primary care office, if you put a printer in every room, rather than down the hall, turn left, go down another hall, you can reclaim a half an hour a day. If you co-locate the nurse and the physician at the same station so that they can interact in person rather than leaving notes and messages and back and forth, you can save, again, close to a half an hour. So following those two simple steps, you can reclaim almost an hour in a well-organized medical practice. And there are lots of other things like that. So that's one. We are also working in the area of innovation to try to remove some of the obstacles that physicians are facing in two different ways. We have an innovation lab out in California called Health 2047, which is looking in the digital space to provide tools to help people reclaim some time and streamline the process. And there is also an incubator in Chicago called Matter, M-A-T-T-E-R, that the AMA has taken a leadership role in. So we're working on this in a lot of different ways.
Well, we're almost out of time, but we truly appreciate having you here today and hearing your insights about the AMA and the healthcare system, and we'd like to thank you for being here, Dr. Gurman.
It's my pleasure. I'd love to come back. Thank you.
And thank you. For Global Perspectives, I'm John Bercia, and we'll see you next time.